Hello, my name is Dr. Gordon Ambayo. I'm a psychiatrist. I have a Master's of Medicine in Psychiatry from the University of Nairobi. I'm the chairman of the Department of Psychiatry, Kenya Methodist University, Meru campus. I have a passion for mental health, and this video is on management of acute psychosis, which is one of the most common psychiatric emergencies. Welcome and listen to the video. Now, the outline of the lecture consists of introduction, definition, causes of acute psychosis, symptoms, diagnosis, and management. Now, acute psychosis is the presence of mental state where appreciation of reality is impaired, as evidenced by the presence of symptoms such as delusions, hallucinations, mood disturbance, and bizarre behavior. It is a medical emergency, and it's a symptom and not an illness. So the underlying cause must be established. It is often accompanied by acute behavioral disturbances. Now, what are the causes? The causes are psychiatric disorders such as bipolar disorder, schizophrenia, postpartum psychosis, dementia, anxiety and stress, psychotic depression, delusional disorders, and schizoaffective disorder. Now, there are also medical causes, HIV encephalitis, cerebral malaria, neurosyphilis, and typhoid fever. Now, there could also be early prodromal symptoms in psychiatric causes of the illness, such as in schizophrenia, where the patient will present with reduced concentration, deterioration in role of functions the patient normally performs in day-to-day. There is also irritability, suspiciousness, and reduced drive and motivation, and anergia. Now, some patients may also have anxiety, social withdrawal, sleep disturbance, depressed mood, and some patients, especially if caused by medical illness, may have acute onset without prodromal symptoms. Now, some patients may also have positive symptoms, and others may also have negative symptoms, or they might have both. The positive symptoms are delusions and hallucinations, formal thought disorder. Then the negative symptoms are flat affect, poverty of thought, lack of motivation, and social withdrawal. Now, patients may also have cognitive symptoms like distractibility, impaired memory, impaired executive function, mood symptoms, depression, and elevation of mood like mania. They may also have anxiety, panic attacks, perplexity, aggression, hostility, and suicidal behavior. Now, the diagnosis of acute psychosis is entirely clinical. It should involve good history taking, and it is always helpful to talk to the patient's family members and friends, especially in early psychosis, as little may emerge from the interview with the patient, and the presence of illness needs to be inferred from the account given by family and friends. So the next step is to stabilize the patient, do physical examination, do investigations, delay treatment worsens prognosis, and monitor for drug side effects. What are the treatment goals? Treatment goals include excluding medical causes, rapid stabilization of acute crisis, avoid coercion, treat in the least restrictive settings, and form a therapeutic alliance, and have an appropriate aftercare plan. A therapeutic alliance involves forming a relationship with the patient, the relatives or friends, so that you can continue managing this patient appropriately in the long term. Now, what are the indicators of medical causes of acute psychosis? The patients may have somatic complaints, vital sign abnormalities like high pulse rate and high blood pressure, which may be indication of drugs intoxication, drugs like marijuana, if taken in high doses, may cause high pulse rate and high blood pressure. There could also be physical signs, signs of intoxication, rapid onset of psychotic symptoms, waxing and waning mental state, and signs of delirium. Now, investigations, we do a full hemogram to rule out septicemia, which may also be a cause of acute psychosis. We do thyroid function test. In thyrotoxicosis, some patients may present with features of psychosis. We also have to do a metabolic profile to get a baseline readings, as some of the antipsychotics patient will use or will have used can cause metabolic syndrome. We also need to do drug toxicology to detect if the patient is using any illicit drugs. We also do salmonella antigen test, as salmonella fever can also cause psychosis. Malaria test, especially if you're in a malaria endemic area, cerebral malaria can present with features of psychosis. We also do HIV test, as HIV can present with HIV encephalopathy, which may have psychotic features. Also do vitamin B12 and folate levels. Deficiency of these are associated with depression and psychosis. We also do liver function tests to get baseline readings. Number two, also, if the patients are using alcohol, then the liver function may also be deranged. Again, antipsychotics can induce liver injury by means of three main mechanisms: hepatocellular damage, cholestasis, and steatosis. So, baseline liver function test will be required to see whether these features develop later on. Now, typical antipsychotics also have a risk of causing hepatotoxicity, especially chlorpromazine, whose cause of liver hepatotoxicity is well known. Other investigations are CT scan, and then you can also do MRI. MRI is a sensitive imaging modality for detecting lesions that are commonly associated with psychosis, including white matter disease, brain tumors, and temporal lobe abnormalities. Now, initial assessment of the patient, what do? You do capacity assessment of the patient to give consent. If they are not able to give consent, then the relatives will give consent and the patient will be admitted involuntarily. Now, you also do risk assessment, the clinical judgment. This is a clinical judgment as to whether the patient constitutes a risk to himself or herself or others. If there is a danger of suicide or violent behavior, inpatient management will usually be needed. Now, assess whether immediate intervention is needed or not, and assess if rapid tranquilizers is needed. Now, what are the predictors of aggression? Number one, it will be past history, intoxication, recent threatening behavior, and then we also have assessment tool, historical clinical risk management, which has 20 questions that you can ask. Now, then you go to calming the patient and rapid tranquilization. We do the escalation, talking to the patient to calm down. This may not work in some cases. Then if it doesn't work, you'll have to do tranquilization. Now, pharmacological treatment, in a few cases, you may require oral medication, but majority will require parenteral medication. Now, parenteral medication, some will have to be given IM, some may have to be given intravenously. If you choose to use diazepam, then diazepam is not well absorbed when given as intramuscular injection, so you have to give it intravenously, 10 to 20 milligrams. You can also use midazolam, 7.5 to 10 milligrams intramuscularly. Midazolam can also be given intravenously. We can also give lorazepam, 20 milligrams, 2 milligrams every 6 hours. Then you can also give haloperidol, start with 5 milligrams IM and repeat as necessary every 30 minutes. Most patients will respond to 15 milligrams. Maximum dose is 20 milligrams in 24 hours. Now, you can then switch to oral haloperidol as soon as the patient is stabilized. You can also use olanzapine, available in injection form. Can give 10 milligrams intramuscularly and repeat every 2 hours if necessary. Chlorpromazine can be also be given. Start with 50 to 100 milligrams and increase to 200 milligrams if no response in 30 minutes. Chlorpromazine may be repeated up to a maximum of 600 milligrams in 24 hours. Now, if there's no response to the first line treatment in 3 to 4 days, change to zyklopentixol, which is also known as clopixol. Give clopixol Acufase or zyklopentixol Acufase 100 milligrams, then repeat zyklopentixol Acufase 100 milligrams after 24 hours. When you're giving clopixol after 24 hours, you can always give also the depot zyklopentixol 200 milligrams at the same time. Now, you may need to repeat clopixol depot after every 2 to 4 weeks, depending on the response of your patient. Now, in cases where the patient had previously failed to comply with the medication, you may need to continue with depot antipsychotics. Now, you may also reduce clopixol depot instead of giving every 2 weeks to every 4 weeks, 200 milligrams every 4 weeks, if the patient is stable on 200 milligrams every 4 weeks. If there is no good response to clopixol depot 200 milligrams, the dose may be increased to 300 milligrams or 400 milligrams as necessary. Now, other injectables depot medication are fluanzole depot, and fluanzole has both antidepressant and psychotic properties. The active ingredient is flupentixol, and is used for treatment of schizophrenia and also has antidepressant properties, as I had mentioned. Fluanzole is available as 0.5 milligrams tablets, 1 milligram tablets, and 40 milligrams depot injection. On day 1, 50 milligrams twice daily, day 2, 100 milligrams twice daily, day 3, then 100 milligrams morning and 200 milligrams at night, day 4, then 200 milligrams twice daily, day 5. So you will continue with the dose that your patient has stabilized on. But remember that the minimum dose for quetiapine is 300 milligrams per day on maintenance phase. Below that, the patient may not respond. Now, risperidone, you can start with 1 milligrams twice daily, increase over a few days to 2 milligrams twice daily, and you can go to maximum of 80 milligrams in 24 hours. Olanzapine, you give 5 to 10 milligrams at night. Then aripiprazole, give 15 milligrams per day and may increase to 30 milligrams per day if necessary. Now, if response is inadequate in 3 weeks, the dose can be increased unless significant extrapyramidal side effects occur to this second generation antipsychotics. Now, risperidone, if response is inadequate in 3 weeks, the dose can be increased unless significant extrapyramidal side effects occur to the second generation antipsychotics. Risperidone can be given 2 milligrams twice per day up to 3 milligrams twice per day. And again, you can increase to a maximum of 8 milligrams in a day. Olanzapine, 20 milligrams at night, the maximum dose. Quetiapine, 400 to 750 milligrams per day. And aripiprazole, up to a maximum of 30 milligrams per day. The other depot antipsychotic is fluphenazine, which is also known as MODECATE. Fluphenazine is an antipsychotic used in the treatment of chronic psychosis such as schizophrenia, and is as equally effective as other low-potency antipsychotics like chlorpromazine. It is given orally or by injection into muscles. There is also a long-acting injectable version that may last for up to 4 weeks. Now, fluphenazine deconate, the depot injection form of fluphenazine, should not be used by people with severe depression. Now, fluphenazine is a typical antipsychotic of the phenothiazine class. Fluphenazine acts primarily by blocking postsynaptic D2 receptors in the basal ganglia, cortical and limbic system. It also blocks alpha-1 adrenergic receptors, muscarinic 1 receptor, and histamine receptors. Also treat other comorbidities like anxiety, agitation, insomnia with short-term diazepam repeatedly as is required. Quetiapine and chlorpromazine can also be used for this anxiety, agitation, and insomnia. Now, a manic presentation may require addition of a mood stabilizer, e.g. lithium, sodium valproate, and carbamazepine. If depression persists, adjunctive antidepressants may be necessary. Now, consider the use of long-acting injectable antipsychotics if adherence is unlikely despite psychosocial interventions or the patient fails to achieve optimal response from oral therapy. Discontinuation of antipsychotics. A gradual withdrawal is recommended when discontinuing antipsychotics to avoid acute withdrawal syndrome or rapid relapse. Symptoms of withdrawal commonly include nausea, vomiting, and loss of appetite. Other symptoms may include restlessness, increased sweating, and trouble sleeping. Less commonly there may be a feeling of the world spinning, numbness, and muscle pains. Symptoms generally resolve after a short period of time. Now, management after stabilization depends on the underlying cause. Schizophrenia, bipolar disorders will require lifelong treatment. Psychotic depression, continue on psychotics and antidepressants at least 6 months after remission, then start tapering. Drug-induced psychosis, if patient stops abusing drugs, they may recover in 1 or 2 years. But those who do not stop taking the illicit drugs may not recover. Acute psychosis induced by medical conditions, e.g. cerebral malaria, typhoid fever, septicemia, etc. Psychosis remits immediately the underlying condition is treated. There will be no need for maintenance and psychotic in 95% of the patients. Thank you for listening. I'm Dr. Gordon Ambayo, Chairman, Department of Psychiatry at Kenya Methodist University. My mobile number is 0722 396986. You can reach me in case you have any questions or concerns. Please share and subscribe.